Hi, this is Dr. Keith Boyd. I'm one of the clinician educators at Rush. And for the next few minutes, we're going to talk about the case of Mark Ryfield. This is the case presentation and analysis. You should refer to the case description, which provides all the details and was provided in your self-study.
Let's start by reviewing the case analysis process. We will revisit this process for almost all the cases that you see in the future. Slowly, you'll develop these skills, and we'll focus for each case on a set of the steps. Since this is pretty early in the year, we're going to go through the entire process. So we'll start by developing a patient profile. These are features of the patient that significantly alter your approach to the differential diagnosis. Typically, things that are included are age, gender, but there are often other things. For example, if a patient presents with a cough or hemoptysis, one might consider whether or not they're a smoker. 2, we'll identify the chief complaint. That's what the patient says is what's bringing them to see you. 3, we'll identify problem cues in the history and physical exam. These are abnormalities in what we refer to as the database. That's the data you get from the patient in the history and physical exam. Remember, this is before you do any diagnostic studies. We'll then group the problem cues that are most likely related to one another. The 5th step is to develop a prioritized problem list. The 6th step is then to write a problem statement which summarizes the presentation of the patient. And the final step is to develop your differential diagnosis that you then go on to test with your diagnostic testing.
Let's start with the patient profile and the patient's chief complaint. For the profile, Mark Ryfield is a 27-year-old man. He does have a past medical history of seasonal allergies, but no other past medical history. The decision you need to make about whether or not to include seasonal allergies up front in his profile is whether or not you think that significantly alters your approach to the differential diagnosis. In this case, you could probably argue it either way. His chief complaint, as he presents to the emergency department, is lightheadedness and nausea. The history of present illness includes the facts that he's lightheaded and nauseous. He had run a race an hour before the presentation on a very warm day, and he felt that during the race he wanted to accomplish a personal best, so he did not stop to drink fluids, even though he knows he should have. The night before, he went out with some friends and drank a fair amount of beer. Probably not the best way to prepare for a race the next day. And the medic at the end of the race measured his blood pressure and told him it was a little low. He has these additional signs and symptoms. Remember, a sign is something that you can objectively measure, whereas a symptom is something that the patient complains of. He's fatigued, he has leg cramps, he reports being thirsty. He's orthostatic, but he's okay as long as he stays in a lying position. And he reports he hasn't urinated for the last 5 hours. Typically, at the end of the HPI, we record what we call pertinent negatives. This is where you're doing hypothesis testing in your head and asking the patient additional questions to test your differential diagnosis. In this case, Mark complains of a variety of different ailments, but he reports no headache, no chills, no abdominal pain, no dysuria, no vomiting, and no diarrhea. Medications include fluticasone nasal spray, which he uses once daily for his seasonal allergies. He has no known allergies to medications. As mentioned before, his past medical history includes seasonal allergies. He also had ear tubes placed at age 2 and a tonsillectomy at age 8. For his family history, his father is 59 years old and healthy. His mother is 56 years old and was recently diagnosed with multiple sclerosis. His brother has asthma, but otherwise is healthy. For the social history, you note that he lives with a roommate. He works for a finance firm in downtown Chicago. He's monogamous in a sexual relationship with his girlfriend. He denies using any tobacco products. He occasionally smokes marijuana. And he binge drinks once or twice a month, as he did the night before the race. The review of systems is done, but does not provide any useful additional information for the case analysis. On physical exam, his temperature is slightly elevated. He has a respiratory rate of 14, pretty normal. O2 sat of 99% on room air, also normal. He's 6 feet tall and weighs 76 kilos, and you calculate his BMI to be 22, which is categorized as a healthy weight. You note that his blood pressure is low and his heart rate is high, so you decide to do the procedure of orthostatic blood pressure, checking for orthostatic hypotension. I've provided a definition for you here and a reference. But basically what you do is measure the patient's blood pressure while they lie down and they're comfortable. You then have them sit up if they're particularly orthostatic or complain of significant lightheadedness or dizziness, as this patient may have. And you may choose to check the blood pressure then while the patient is sitting up. Remember to also check the pulse. And then you can ask the patient to stand and again check their blood pressure and heart rate. And you can see in this case there's a significant difference. The significant findings of the physical exam include the fact that the patient appears fatigued, that he has dry mucous membranes, and that he's tachycardic. And then, of course, the orthostatic blood pressure that we just noted. The next step is to develop the problem list. A problem list should always include any item in the history of physical exam, we refer to that as the database, that is abnormal. So you don't need to make a judgment at this point of whether you think it's related to the chief complaint or not. You just need to decide whether it's normal or abnormal. If it's abnormal, it gets included on your problem list. Once you've developed this list of problems, you then sort them into groups that seem related. So here's Mark Ryfield's problem list for this presentation. I'll give you a minute to look it over and make sure you understand each of the items. The next step is to consider how you might organize this problem list into problems that seem to be related to one another. So I put this set of problems together because it seemed to me that I could draw some relationships between them. As you look through the list, you can postulate that all of them are related to the fact that he's probably dehydrated. These were problems that I put together that didn't seem directly related to his dehydration. I wasn't quite sure how to categorize them, but they're all related to his social history and, of course, the fact that he was out drinking beer the night before. You could argue that that might have something to do with his risk for developing dehydration the day of the race. But otherwise, these are more related to social issues that you might discuss with him in this visit or in another when it's more appropriate to address his ongoing health. After developing the first two set of problems, then I have this third set of problems that I'm not sure how to relate to the other two groups, so I list them separately. You then want to update the patient's problem list in the medical record, and these are the issues that you might record or update in his record, or just make sure that they all appear in his record. These are problems that are going to stay on his problem list and are not necessarily related to the acute presentation. The next step is to develop the problem statement. The problem statement should be a complete but concise presentation of the patient that helps you launch the most efficient differential diagnosis. So this is as much art as it is science. There are many ways that one can structure a problem statement for any given case. This is just one example, and you might have others that you could look at. You might have problem statements that emphasize different elements in different ways, and this is always going to be the case. But let me read this one for you. Mark Ryfield's a 27-year-old man who presents with postural lightheadedness, leg cramps, oliguria, and nausea after running a race in warm weather. He neglected to adequately hydrate and had low blood pressure at the end of the race. On exam, he's tachycardic and hypotensive when standing. His mucous membranes are dry. Again, lots of different ways you can do this. You'll have lots of opportunity to practice. There's no one single correct problem statement. Now we go on to develop a differential diagnosis based on the problem statement. I want to point out that one option in this case would be to develop that differential diagnosis and then not perform any diagnostic testing at all, but rather treat the dehydration and reevaluate the patient. That's not done in this presentation because we want to give you some additional numbers to work with that'll form the basis of some of the exercises for this session. So in this slide, I list some of the possibilities for the differential diagnosis and how you might consider evaluating that differential. For nausea, you might consider a comprehensive metabolic panel to look at his electrolytes and the other features of the CMP. Note that nausea actually is a patient complaint and not a specific differential diagnosis. His binge drinking, you might consider whether or not there could be effects of that over the longer term and might consider liver function studies. Those would be included in the CMP. His muscle cramps, a consideration especially after running, would be the breakdown of muscle tissue or rhabdomyolysis. A CPK would be helpful in evaluating that possibility. And then our leading differential of dehydration could include something like acute tubular necrosis, where the tubules are damaged as a result of lack of perfusion. So in a urine analysis or a fractional excretion of sodium will be helpful in evaluating both dehydration and the possibility of renal involvement. So here you see the results of the comprehensive metabolic panel, and we've bolded the abnormalities for you. There are two in this case, although you look at the creatinine phosphokinase and it's certainly on the high end of normal. So that is something to note. But otherwise, he has a high BUN and a low serum sodium. Again, you're looking to see which of your differential diagnoses does this support. Here's the results of his urine analysis. The color is noted to be dark yellow. His specific gravity is 1.050, which is extremely high. Remember, the specific gravity does not have units. It's a comparison to a measurement of water. And so when you look at the specific gravity of water is 1.0, and everything else is compared to that. And in this case, again, it's consistent with significant dehydration. The rest of his urine analysis is normal. You can see that there's no red cells, no white cells, no casts. So there doesn't seem to be any evidence at this point of any renal involvement. You measure squamous epithelial cells as a way to see how pure the specimen is, how much of it's actually coming from the urine. If you see a lot of squamous epithelial cells, that may indicate that you don't have a good specimen, because those should not be in the urinary tract. We provide you with these additional urine results because we want you to work with some of the numbers to better understand how in patients we can measure the impact of dehydration. And so these numbers probably in this case would not have been collected because, again, it would have been more prudent to treat the patient and reevaluate the patient before pursuing tests such as these. But again, we provide these so that you can learn how to work with these kinds of numbers and understand their meaning. So as we interpret the results of our diagnostic studies, we notice that the serum sodium is low, the BUN is high, the creatinine's a little high, although it's notable that the patient will have a baseline creatinine that's best to use as a point of comparison. and the urine is dark, the specific gravity is high, and there's no casts present. So given all this information, we can pretty confidently land on the final diagnosis of dehydration.